So first question, what is peripheral neuropathy? Peripheral neuropathy, it's important to understand neuroanatomy. So the anatomy of the body is made up of the central nervous system, which is the brain and spinal cord. And then we call peripheral neuropathy anything that exits outside the spinal cord. So we have our brain, we have a spinal cord, and we have individual nerve root segments that come out at each individual level. They coalesce to form the larger nerves down the body. So when we say peripheral neuropathy, we're talking about the nerves outside the spinal cord. Now, some people have pain, numbness, tingling, paresthesia, loss of balance, things like that from spinal cord issues, but peripheral neuropathy is not that. It is damage to the nerve outside the spinal cord, outside the CNS or central nervous system. So we have to understand what we're talking about. Most peripheral neuropathy has a stocking glove distribution. Not all. There are some other mononeuritis. There's radiculopathy, which is nerve root impingement. But strictly talking about peripheral neuropathy, the distribution is often in a stocking glove. What that means is picture having a pair of socks on and picture having some gloves on. Those would be the most common sites for you to have symptoms. So typically when the numbness and tingling or pain starts in the foot, you'll start to notice it as it comes up. Then when it hits about mid-calf and things like that, it'll start to develop in the fingers and it'll progress northward from there. So it's a length-dependent problem. The nerve is damaged distally, and you'll get symptoms that tend to come back up from there. So some examples of nerve problems, let's say in the arm. We use a mnemonic in school. Randy Travis drinks cold beer. So you have your brain and spinal cord, and then you have your roots, trunks, divisions, cords, and branches. So, and then those branches give way to the peripheral nerves in the arm. So that would be things like the median nerve here, coming around the elbow, the ulnar nerve, the radial nerve comes through here, and then you have the musculocutaneous nerve up in here, as well as the axillary nerve innervating the shoulder. However, it's important when we talk about peripheral neuropathy, it oftentimes doesn't affect just one nerve. It affects the distal tips of the nerves in all the extremities. So you'll get some slowing of those nerve fibers and all the nerves coming back up through there. Okay, there are a number of different types of nerve fibers, and this is very important because if we discuss the nerve fibers, then you can figure out what kind of neuropathy you might be having. So there's a large fiber, which are big nerves, and they carry lots of information. They carry information from the muscles north up to the brain. They carry information from the joints, so things like balance, touch on the skin, things that need to get to the brain quickly. Those are very large fibers, so those go north. Then there are small fibers, which are tiny little fibers. They don't have a fat sheath around them, and those transmit fibers a little bit slower, and we run pain and temperature through those nerve fibers. And then the last nerve fiber involved can be what's called an autonomic fiber, and those are the nerves to, let's say, the blood vessels of the arm. So if you have symptoms in, let's say you have a peripheral neuropathy, let's say you have a diabetic neuropathy, and it's affecting large, small, and autonomic fibers. So a large fiber, you might have lots of tingling and numbness because those large fibers transmit those sensations. And if you have a large fiber neuropathy, those are the experiences you'll have. You'll also have some trouble with balance. You might notice that you can't stand on one leg very well. You might lose some reflexes, loss of sensation, like if somebody was to touch you. That's a large fiber neuropathy. You might also have a small fiber neuropathy that's characterized by loss of temperature or pain. You'll get it'll be a painful neuropathy. And lastly, an autonomic neuropathy, you'll start seeing changes in the skin, lots of dry skin, breakdown, things like that, and that's a clue that it could be affecting the autonomic nerves. Now, there's only good ways to test the larger diameter fibers. You can't really check for a small fiber or an autonomic fiber neuropathy with conventional testing. Oh, I don't want to forget motor neuropathy. Sometimes people will have damage to the nerve to the muscle. So it's difficulty with contraction, so you get some weakness in there. And I do see that number of cases of alcoholic neuropathy that we have, the patients will get a lot of weakness accompanying their other symptoms. So you can really take a look at what symptoms you have, and you can probably figure out whether you have purely a sensory large fiber neuropathy, or is it large and small fiber, or if there's some autonomic component, or if there is a motor component to the neuropathy. And so different diseases will kind of tend towards different aspects of which nerve fiber is damaged. So that's important to know. There are some hereditary neuropathies. Kind of a classic one would be called Charcot-Marie-Tooth, and those are diseases of the nerve that you inherit. And it becomes apparent as you get older, and usually there's a family history of, mom or grandma was in a wheelchair at an early age. Usually these people are marked with very high arches, and they have what's called a champagne leg deformity. So they're the nerves are damaged to the muscles, especially in the lower leg, and they'll get very thin kind of champagne flute glass is of the leg, and characteristically you'll see very high arches and some hammer toes. So if you have those things, it's important to get checked out by somebody who specializes in that hereditary neuropathy. So, okay, so that is the peripheral nervous system, and so now we have some of the classic types of peripheral neuropathies that we can see. Let's go into it a little bit deeper. What causes neuropathy? Well, diabetes is a common cause in the United States. Probably it's the most common cause. I was reading an article a few years ago. Worldwide, though, in other countries, we see things like leprosy as a cause. However, that we don't have that disease here, and diabetes is a much more common cause. So the sugar and insulin are extremely toxic to the nerves, and you end up getting some microvascular changes. So we get some damage to the small nerve endings, and the blood supply, especially to the outer fat sheath, starts to diminish, and the nerves start to die back in a length-dependent fashion. Let's see, what else can we talk? Nutritional causes. Alcoholism really lowers some B vitamins, especially thiamine, niacin, riboflavin, things like that. B12 issues can cause neuropathy. Now I want to take a second here and talk about the widespread use of a proton pump inhibitor. So those are things like omeprazole, Prilosec, things like that. What people take if they feel like they have too much stomach acid. Those long-term use of those can really inhibit the absorption of B12, and that can be a source of neurological issues. So in a lot of our patients, we will be checking labs, and we will want to check some B12 levels and even folate and some of the other vitamin levels to make sure we haven't missed an underlying metabolic neuropathy. So it's important, if you are taking those medications, you can't just suddenly stop. I know they are over the counter now, but you can't just suddenly stop those, because in the top part of your stomach there is it releases a hormone called gastrin. And if you're taking those kind of medications, the gastrin levels will be pretty high, and so when you abruptly withdraw, suppressing the acid, you'll have kind of a reflexive dumping, and so you'll have a lot more acid that can aggravate your symptoms. And so you have to do that very carefully, usually under the guidance of somebody who knows what they're doing. So go off slowly if you do that, and talk to your physician or nutritionist about that. Thyroid issues can cause entrapment, because it's interesting. Often we see people with endocrinopathies, diabetes, thyroid. You'll have some interstitial swelling, and that swelling will put some pressure on the confined spaces. So you'll start to see people who otherwise healthy may have been diagnosed with a thyroid problem or may not have, and they start getting some numbness and tingling in the fingers, or they get some tingling in the feet and toes if they're runners. And it's oftentimes from some endocrine changes that we want to make sure we're catching, and we're optimizing all that stuff and supporting that. Infections can cause neuropathy as well. Shingles is a classic case. It's a virus. So if you have a virus that kind of lays dormant for a bit, we kind of coexist with lots of viruses. And if your immune system is just a little dysregulated and you've had some shingles attack, you know exactly what I'm talking about. These viruses will come out, and they'll typically hit a nerve root distribution. So that can cause a neuropathy. Usually it's just affecting one nerve. It's not a widespread kind of classical peripheral neuropathy. That's just a certain type of nerve damage. HIV can also lead to some neuropathic issues. Chemotherapy targets rapidly dividing cells and cells that have a high metabolism, and so sometimes nerves are damaged. In radiation as well, we've had a number of cases of radiation, plexopathies and things like that. Heavy metals, mercury, lead, arsenic, even slow doses over long periods of time are important to rule out and see if you're having any issues with that. That could be contributing to some of the nerve damage. Nerve tumors and cancers can sometimes cause neurological changes, and so we want to make sure that that's not the case in your situation. Kidney disease, when excessive waste products build up, that can be harmful to the nerves in your body as well. Inflammatory diseases, celiac disease, can cause neuropathy. So, if you do have some sensitivities to gluten, you really need to be very careful. Interesting enough, celiac and gluten sensitivities also affect part of the brain called the cerebellum. So one of the things, if we do suspect a neuropathy in a patient and they have signs of it and we do an EMG and there's evidence of it, and they have all the symptoms of neuropathy, we'll check their balance. And commonly in neuropathy, you'll lose balance because those nerve endings that are going to the brain from the small joints giving us feedback to keep us upright, those tend to be a little damaged, and so we rely upon our vision and our inner ear to compensate for that. But if balance is getting worse, we'll do some cerebellar checks too, because gluten oftentimes will cross-mimic and react and kind of cause some inflammation in the cerebellum. And you don't want to miss an opportunity to test for some gluten and see if that's contributing to at least some balance problems. There is a small percentage of people with balance issues improperly diagnosed with neuropathy when it's actually a gluten sensitivity. It's called gluten ataxia, and I've recently had a few cases of that as well. And you can have both. You can have peripheral neuropathy, you can have diabetes, you can have other types of neuropathy, and gluten ataxia as well. So we want to uncover all of that and unpack it so we do make sure we're not missing anything. Common symptoms of neuropathy. Getting back to the first part of our conversation, it depends what fiber is involved. So again, if you have a large fiber involved, a large sensory fiber, you'll be seeing numbness and tingling, paresthesia. Your nerves don't feel right. You'll feel like the skin is crawling. If it's a small fiber, you'll have pain and burning. If it's a motor fiber, you'll have weakness. If it's an autonomic fiber, you commonly see skin changes. Real dry skin is a common one. And another little indicator, this is really interesting. I was at a few lectures, and the lecturer talked a lot about if you see chronic nail fungus, sometimes that's an indicator that there's poor circulation. And so we want to see if there's poor circulation, is there some issues causing that? So is there diabetes there? Is there microvascular occlusion? And so sometimes that's an indicator. You stop growing hair on the lower legs, your skin is real dry, you've got a lot of fungal infections in the toenails. That's a sign that neuropathy could be around the corner for you, so we want to head that off at the pass. All right, how do we diagnose neuropathy? Blood work is a place to start. Do you have the diabetes? Do you have thyroid? Do you have enough B12? Do you have enough B6? Do you have autoimmune diseases? Do you have infections? Do you have Lyme? Do you have, the list is, endless. Do you have a viral infection? Is there a genetic component? Do you have Charcot-Marie tooth disease? So we really want to make sure that we've uncovered and really got the right diagnosis so we can support the right patient with the right therapies. Next is EMG. If you've had neuropathy and you've been to a neurologist, you probably had an EMG. It's that machine back there. What that does is fascinating. The EMG, it's really two tests. One is called a nerve conduction test, which stands for, we call that an NCV, which stands for nerve conduction velocity. The next test, or the next portion of the EMG, is the EMG itself. So nerve conduction velocity means we check to see how fast the nerves are traveling, in a sense, to see how many of the nerves are firing, and then how fast the nerves are firing. So we'll put some electrodes in the hands or feet, in different spots, and we'll stimulate the nerve, and we'll be able to trace the recording and to see if you have plenty of nerves that are firing very healthy and they're firing 50 meters per second, or if they start to slow down. And why are they slowing down? Is it diminishment from being entrapped somewhere like a carpal tunnel, or is it diminished from actually nerve damage and you're starting to degrade the outer sheath of the nerve fiber or the actual axon itself? So that's what we call a nerve conduction, or EMG. Very important test. Very important test. The second part of the test, the EMG, stands for electromyography, and that's where we stick the needle in each individual muscle that the nerve supplies, and we see what the muscle's doing. This is fascinating. As the nerves to the muscle start to die back a little bit and they're not functioning properly, the muscle will repopulate the outside membrane to try to soak up more nutrients, to try to soak up what's called acetylcholine. So if there's nerve damage, the muscle membrane remodels itself and it starts acting very wonky. So we stick a needle in a muscle and we just listen to it. Healthy muscles, when they're not being used, they're silent. They just sit there. When we contract them, we see all sorts of activity. These little spikes that go like that. There should be a lot of them and they should look really healthy. When the nerves start to die back and we stick that little probe in the muscle and we just listen, if the muscle has been remodeled, that membrane will just start to soak up some of that extracellular acetylcholine and just start firing spontaneously. So that's a good indicator that, hey, you've got a problem with the nerve. So we look at the muscle to diagnose a problem with the nerve. So that's called an NCV EMG. So it's not necessary to diagnose it, to use that to diagnose neuropathy if you've got a good physical exam and you've got an astute doctor, but it can be really helpful to kind of chart the magnitude. Make sure there's nothing else going on. There are certain things that show up. You want to make sure you don't have any really severe conditions like a Lou Gehrig's disease or those other things. So it is kind of important to have that test done. Thorough exam. This is my pet peeve, so I'm going to vent a little. Many patients don't have a good thorough exam. So it's important to really have just a detailed and thorough look at all the different nerve fibers involved. So a good exam for a neuropathic patient includes a good history, lab work, nerve conduction, but then we want to do an exam. So we use this thing. It's called a hammer, reflex hammer. So people with nerve damage, the reflex will be diminished. So if we tap their knee, it should be a normal response. But if we tap their ankle, because it's remember a stocking glove issue, we might see a diminished reflex. And sometimes that's an indicator, hey, is there something going on with the nerve? So if they've got healthy reflexes everywhere except their ankles on both sides, and they don't have a spine condition like a herniated disc or stenosis or whatever, then that can be an indicator, hey, we could be dealing with that. So you got to check the reflexes. I carry this around all day long. I'm tapping reflexes for the past 21 years all day long. Okay, next one. This is a tuning fork right here. This is a cool tool. So this checks vibration, which runs through a large fiber. So what we'll do is we'll hit it. So you do this, and we'll get a baseline. I'll typically get a baseline for a patient like right here so that they feel it. Then we'll call this 100, and then we'll do that again to each of the extremities, the knees and the feet. And oftentimes in the peripheral neuropathy, if there's large fiber damage, we'll start to see a reduction in the way people feel it. So they'll feel a lot here. We'll call this 100. And their hands are 100. Their fingers are 100. Knees are, 80. We get down to their ankles and toes. They're 20. They can barely feel it. So we know that there's been some large fiber issues on that one. Okay, this is a pinwheel. Right here. It's like a pizza cutter. We trace individual nerve roots. So getting back to the first question, or the anatomy question, remember we had our brain and spinal cord and then the nerve roots. We talked about Randy Travis drinks cold beer. Well, certain nerve roots will come down and they'll innervate the skin. So we'll be able to, we use this to trace along what's called a dermatome to see if there's, if it follows what's called a radicular fashion. So we can tease out, do you have a spine condition? Do you have a herniated disc that's making the neuropathy worse? So we want to really tease out, okay, do you have a problem with the spine? Do you have a problem with the roots? Do you have a problem with the herniated disc? Or do you just have peripheral neuropathy? Or do you got a little combination of all four there? So we use that. This is really cool. This is called a tip therm. If you see the top here, this is metal, so it's kind of cold. So if I put this here or on somebody's face, they'll feel cold. But the opposite side is just plastic. It feels warm. And so this can check for small fiber neuropathy. So we'll run this and we'll put this on different parts of the body. And then when we start getting the areas where the neuropathy is involved, if the small fibers are involved, they won't feel it as much. They'll start to go, yeah, I don't really feel that. If that's warm or cold, I can't tell the difference. So whereas the nerves are healthy, they can tell, hey, that's cold and that's warm. So we want to check that, see if they have any small fiber neuropathies. This is a cool little tool. If you look here, this one's bent. So these have, actually I should have got my other one. These have a little, they have a measured distance between each point. Between there and there is 20 millimeters. Between here and here is 15. Between here and here is 13, that kind of thing. So we'll test what's called 2-point discrimination. And on your fingers, you should be able to tell, you know, I'm pinching or I'm pushing, getting 2 points instead of, oh, you know, people with neuropathy, I'll put the largest one on there and they'll only feel 1 point because the nerves that discriminate, 2-point discrimination, it's called, will be damaged. So we check that. We can also check light touch with some cotton balls, and we see if they can feel it, and then we can chart that. I like this. This is really cool. This is from Home Depot. High dollar, very high tech. We could, it's a laser pointer. So my wall back there, where I'm pointing, I don't know if you can see it somewhere back there, is 78 degrees. So I'll use this to see if there's some circulation issues. It's like the poor man's circulation test. There's much better tests, but it's a great in-office tool. If we see a lot of, we have the patients kind of equalize, they're wearing shorts. If we see a significant reduction in the temperature between their tips of their toes or balls of their feet and then on up, they definitely could have a circulation issue. We want to make sure we address and try to do some things naturally to improve circulation. So that's how we diagnose. We covered blood work, we covered nerve conduction EMG, thorough exam a little bit. What I didn't show you is something called a monofilament test. Let me see if I have one here. I didn't bring it. It's a little piece of hard, thick fishing wire called a monofilament, and you push that in right to the point where it bends on the distal tips. And there's researched places to put it on the pads of on the tips of your toe pads and on the balls of the feet, and you press and see how if the patient can feel it. And oftentimes with certain types of large fiber neuropathies, they won't be able to feel it. So we document all that. We want to get a good exam. We document it. We'll start to see. We'll draw lines on patients, take pictures. Hey, this is where it looks like the neuropathy is kind of from here down is being affected, and we'll see if we can get some improvements there. Okay, let's see. Medical treatment. Most patients are offered by their neurologist gabapentin or Lyrica. Gabapentin is used to control seizures and relieve nerve pain from neuropathy and shingles. Neither gabapentin or Lyrica is tolerated very well, and quite a few of my patients don't like the way that it makes them feel, and they would prefer to have some extra help and support for that rather than relying solely upon gabapentin and Lyrica. Natural treatments is very important. We want to make sure in lab work, is there any B vitamin issues? Have they been taking a proton pump inhibitor? Do we need to do some GI work, some clinical nutrition to improve their GI tract, to make sure they're absorbing their nutrients? I can't tell you how often we have patients with neuropathy that have been on proton pump inhibitors forever. They have chronic stomach pain and their B12 levels are 190, or we have vegetarian patients and they're low. So we want to make sure we check all the labs. We want to check B12, thiamine, and other vitamin levels. We want to check thyroid issues. Does the patient need to be referred out for some thyroid medication? Or is there subclinical thyroid going on, or they just need a little selenium in their diet to improve some function there. We want to check the sugar levels. We want to check your A1C. Make sure that is spot on. Hopkins says 4.8 to 5.2 is perfect. Pre-diabetic is 5.6 to 6.4. Over 6.4 is diabetes. And very commonly, at least in the United States, that's the #1 cause, is chronically elevated blood sugar. And you can even get peripheral neuropathy if you're a borderline diabetic. So it's important to take those 6.0s and 6.1s and get them down into the low 5s if we can. So it just takes longer to affect and cause damage than regular diabetes does. So if you're a pre-diabetic, you just haven't bought the t-shirt yet. It's coming. Inflammation and C-reactive protein. We use these markers to see if there's any underlying inflammatory changes, which can be irritating to the nerves as well as the brain, and triggering what's called a glial cell response. We want to check homocysteine levels. Sometimes people have trouble assimilating certain B vitamins, especially folate, in their diet, and if they have high homocysteine levels, that will cause neuropathy. So the homocysteine levels we look at, we want to see them in single digits. So if your homocysteine level is 15, you're getting blood vessel damage as well as nerve damage. You want to see that, around 7 or so. So, and that could be related to a what's called an MTHFR defect, which is pretty common, very common actually. So we want to make sure you don't have any of that. Infection support. If you've had shingles a number of times and you're a young person, we want to make sure that we're influencing the immunological system to control maybe some viral issues. If that's the case, that's not usually the case in peripheral neuropathy. Those are more the case in just kind of neuritises from viruses, though. So that's some of the nutrition that we'll want to do. Cold laser therapy increases mitochondrial production. Let me see if I can find mitochondria. So cold laser therapy we do, the treatment takes about 10-15 minutes per leg, and it increases the kind of cellular respiration and the health of the existing nerves. So we can protect them as well as start to heal some of the damaged neurons. We use infrared therapy, and this is, there's a couple on the market, but let me see this one here. Let me see if I can show you a study. Here's one that we use. Whoop. I don't know if you can see this or not. This was published in the, well, let me get my face out of the way here. The journal Practical Pain Management by Dr. Burke. And he had 493 patients. All patients initially experienced painful lower legs. 248 of the patients were diagnosed with diabetes, and the remainder was not. The study reports the clinical outcomes for patients doing infrared therapy. So they did 15 45-minute sessions three times a week, and they checked pain scales and things like that. So results, infrared therapy, 64% reduction in painful symptoms. And this is natural. This is not gabapentin or Lyrica. This is something we strap on you. It takes a long time. We strap on you, and you have to sit in the clinic for half an hour just getting it done 3 times a week. But it's very effective. 64% reduction in painful symptoms. 51% of patients right here reported reducing the need for prescription pain medication after treatment. Next study. This is in the Journal of Diabetes and Its Complications, 2006. This is by a bunch of podiatrists. Improved foot sensitivity and pain reduction in patients with peripheral neuropathy after treatment with monochromatic infrared phototherapy. So these people took, they analyzed 2,200 patients from 1,000 different doctors who'd been prescribed treatment for their neuropathy, probably gabapentin or Lyrica. All patients reported discomforting foot sensations, and 1,563 patients reported pain in their lower extremities. Of that, 1,395 patients were diagnosed with diabetes, and the remainder was diagnosed with other conditions that may have been associated with symptoms. So of the 2,239 patients, with painful feet and were being treated for neuropathy. 1,395 patients had diabetes or were somewhere on the spectrum. And so here's what they did. Results. They used the infrared device that we use here. 98% of patients reported significant reductions in pain. That's phenomenal. After treatment, the patients experienced only mild pain, 2.4 out of 10, compared to extreme pain, which was a 7.2. So their initial pain scale, their average pain went from 7.2 down to 2.4. And this is a big study. On average, pain decreased by about 67%. Okay, next study. Physical and occupational therapy in geriatrics. And this was done by a couple of PTs, as well as Dr. Burke again. The effectiveness of monochromatic infrared phototherapy and physical therapy for peripheral neuropathy. Changes in sensation, pain, and balance. A preliminary multi-center study. So what these guys did, 272 patients were treated. Let's see if we can just sum it up real quick. Of the 272, 128 patients were diagnosed with type 2 diabetes, and 144 patients were diagnosed with other conditions that may have been associated with their symptoms. So 272 people with numbness, tingling, pain. Of those, 128 of the 272 were diabetic. So after 18 35-minute treatment sessions at 3 times a week, results, more than 90% of patients reported significant reductions in lower extremity pain, relief from discomforting foot sensations, and improved balance. Okay, and we've got a bunch of other studies we could go through, but I think you get the picture. So we use a cold laser, which you got to wear these glasses for. We do some infrared therapy, which does take a long time. Let me go back to here. The infrared therapy that we use, we strap on devices to your legs, and you just have to sit there for about a half an hour. It's very effective. I really like that. I think that's an extremely effective tool that we use. Next, what's interesting, we'll be using, let me see if we can get this up here. We've been experimenting with devices similar to the Rebuilder here. This is interesting. It's a patented device that Cancer Treatment Centers of America use for when they have patients. I would imagine, it doesn't say in this little pamphlet that they who's using it, but it could be chemotherapy-related neuropathy or radiation-induced neuropathy, or in fact just neuropathy from the cancer itself. But they've been using this device for over 15 years with a 93% success rate to reduce both pain and numbness. So this is a great product. And normally with this therapy, I'll just let the patients take one home, and you do it at home, because otherwise you'd be in the office for a long time. That's something that we have the patients do for about an hour a day on their own. Okay, we also use vibration therapy to help stimulate the receptors on the bottom of the feet, and that can help reduce a lot of the pain and improve balance. And then we do a nerve kind of massage called myofascial release, where we trace the nerves and help improve if there's any restrictions in the fascial planes that can irritate the nerves. We'll free them up. Okay, so a combination of cold laser, infrared therapy, kind of TENS microcurrent that we talked about. We'll do some clinical nutrition, some vibration therapy, myofascial release therapy, and so we've got a good program. Next, nutrients that help therapy, that help neuropathy. We want to make sure that we correct if there's any B vitamin issues, and we want to make sure the GI tract is working properly, and that there's no absorption issues. Alpha lipoic acid helps prevent damage to the cell. Acetyl L-carnitine can be helpful. N-acetylcysteine and glutathione can improve mitochondrial support. Curcumin resveratrol lower a cytokine called Th17, and that can be very helpful in preventing, in reducing some of the inflammatory changes in the pain and preventing any kind of autoimmune issue. Those can kind of dampen that response. We like to use fish oils, vitamin D, vitamin A, Intermittent fasting we use commonly, especially if there's a dysglycemia or a diabetic component. So we have lots of different therapies that we invoke and stuff. One last thing I thought we should go through. This is an interesting hey there thing that I don't know if you got this. I had some technical issues, but anyway, starting over. So it's important when discussing neurology that we understand this concept. This is why some people have really hypersensitive nerves. So as the neuropathy progresses, you're going to get nerves that are dead. They start to die back, and some of that, you just get no symptoms. But then you start getting nerves that are unhealthy. So there's that zone between unhealthy and dead and healthy tissue. And that's where people develop a lot of symptoms. And it's important to understand this concept. So healthy nerves right here. Okay. The inside of the nerve, here's the nerve, is much more negatively charged than the outside. Okay. When you have a stimulus, so your joints, your muscles, whatever is stimulating, and you're sending signals back up to the brain, you create an action potential and it zooms down the nerve or up the nerve, goes to your brain. So the outside is negatively charged. Healthy nerves have a large resting membrane potential. So negative 70 millivolts. So the inside of the nerve is more negative than the outside, about negative 70 millivolts. When there's a stimulus to the nerve, either, let's say, light touch, muscle contraction, joints are moving, anything that the nerve does, muscles are being stretched, there's vibration, there's heat on the nerve, you stepped on a nail or whatever, you're going to get a stimulus. Okay? You're going to get a stimulus. The nerve will fire and register once it hits the threshold, and then it's all or nothing. So you can have some low-grade stimuluses that don't set the nerve off until it reaches the threshold to fire. Got it? So unhealthy nerves. Here's our unhealthy nerve. The inside resting membrane potential might be less negative. So instead of resting down here at 70 millivolts, stop. I don't know why it keeps doing that. But I can deal with this. So instead of resting here at negative 70 millivolts, it's a lot less negative, and so it requires far less stimulus to set the nerve off. So let's say we're dealing with the pain fiber, and normally we won't experience pain. Our nerves are quiet. It takes a lot of stimulus for us to have discomfort, but as the nerve gets unhealthy, we become more easily stimulated, and so we have an action potential up here, and these people have nerve symptoms. So this is an interesting thing. Now, what causes this inside the cell to be healthy is a little, if you remember from biology or chemistry or biochem, there's something called a mitochondria. And what the mitochondria do is they drive the sodium and potassium pump. So mitochondria, healthy mitochondria, have a good system of keeping the inside negative. It drives the sodium potassium pump. So it creates energy, ATP, to run the cell. And so it keeps a healthy membrane and the healthy nerves. And so when the mitochondria become unhealthy or sick, if there's not a lot of oxygen or there's a lot of inflammation, there's not a lot of glutathione, or there's damage or who knows what, and the mitochondria is not as efficient, that becomes less efficient, leading to a higher resting membrane potential, and then you get symptoms. So this is important. This whole concept is important in why we want to address the patient, not just with the physical therapy kinds of treatments and the infrareds and things like that, but we want to address this with nutrition. And I can't stress how important that is. So let me get rid of that. Maybe. Oh, there I am. Sorry, I'm not used to this software. Okay. That's it. If I have any last questions, I'll make an addendum that I think should be answered. I'll make an addendum to the video. I think we accomplished a lot. I talked a lot about the different types of treatment we do. Hopefully you're better educated about neuropathy. I'm happy to consult with you if you have any questions, and I think that's it. Have a great day. And again, this is Dr. Ratcliffe. If you need to reach us, You can send me an email at office@novachiro.com or call the office at 703-444-4446. Take care. Bye.